Is that a yes or no? Okay. There is radiology on the exam, close to 5 questions. Yeah, for ICM. Please do the Q stream. I will post the link again on Facebook and send out an email. And just a reminder, ICM Men's Health Fair tomorrow, mandatory. There's 2 lists. It's split alphabetically, so please be sure to bring your ID, your stethoscope, your blood pressure cuff, all of that business, because you will be taking vitals. Bring a clipboard and a pencil with you as well.
Behavioral, I did ask about the vocabulary, about a reduced list or an increased number of questions on vocab, and he wouldn't agree to either. He said, we've had all semester to study for vocab. We knew it was going to come, so vocab is set. And today, if you, he'll give an approximation of a breakdown. If you have any questions about vocab, about the exam, feel free to ask him. He's a nice guy to talk to.
It's been real, guys. Last day of school. Congratulations on making it to Med 3. Study hard for finals.
Hello? Yeah. Final is just what is on the, on the blackboard. We have given you the breakdown of the topics, isn't it? Only those.
Just making sure.
Yeah. Okay. Hello. Okay, so what we'll do is we'll start with the viruses today. We'll review them and continue on Tuesday, and then I'll wind it up with just a few topics, what you essentially need to focus on in immuno. Okay, so the immunology, the questions would mostly focus on, now that you have done all the microbes, it would be more of the immune response in terms of the various, microbial diseases. Anyway, I'll tell you about that on Tuesday. So let's first concentrate on the major chunk of what's going to be there on your final exam. That's the viruses. Okay. So once again, let me reiterate that viruses, unlike bacteria, they don't have any virulence factors. So you need to know whether a virus is a DNA or an RNA virus, whether it is enveloped or non-enveloped, the site of its replication, whether there's any unusual feature about the virus, whether it has a segmented genome, whether it has a single-stranded or double-stranded, nucleic acid, and also some of the viruses exhibit characteristic CPE in the cells that, where it's replicating. So can you give me an example of a CPE that comes to your mind? Cytopathic effect. The virus is multiplying in the host cells and it causes some changes in the host cells, which is useful in identifying the virus. Can you give me an example? No, a CPE typically, yes? Anyone? At least I just want to know whether you understand what is a CPE. Now, can you hear me? I think something to do with the, now? Because I won't be able to write and hold the mic. Is it okay now? Okay. So, what are owl's eye inclusions? So, owl's eye inclusion is an example of a CPE, cytopathic effect. Why do you see owl's eye inclusions? Which virus produces owl's eye inclusions? The cytomegalovirus. So when cytomegalovirus is replicating in the target cell, what is the site of its replication? It's a, what's a nucleic acid of CMV? It's a DNA virus. So where would it naturally replicate? In the nucleus. It multiplies in the nucleus. It causes the enlargement of the nucleus, and it also causes the enlargement of the host cell in which it's replicating. That's why you see owl's eye. Owl's eye because both. And why does cytomegalovirus, what is the meaning of the name? Cyto refers to cell. Megalo, big. Yes. So it causes the cell in which it's replicating to enlarge. And typically you see those owl's eye inclusion because it causes the nucleus also to enlarge. So that's one example of CPE. Okay, so you know there are various viruses, some of them show characteristic CPE. Anyway, we'll focus on that now. So let's start with the DNA viruses. Let us first look at the herpes family of viruses because that's a very important group of virus. Okay, so what is the main characteristic of herpes virus, the whole family, that you should never forget? Something about the nature of that virus, which when we say herpes viral infections, the latency, okay, amongst all the property, remember every one of the herpes viruses can remain latent and, complete the sentence, and reactivate. Yes, reactivation. So latency and reactivation of herpes virus is an important concept that can get tested. Give me an example of the viral latency and reactivation in terms of a disease. Huh? A common, yes, varicella going latent and reactivating as shingles, isn't it? So that's one example. Then you have primary gingivostomatitis, cold sores, reactivation, okay? Then you have cytomegalovirus going latent and reactivating in transplant patients and causing so much of problems in transplant patients, okay? So herpes viruses, always keep that in mind, latency and reactivation. So let's first look at the HSV virus. We look at herpes simplex virus 1. So this is HSV 1. So what are the characteristics of this virus? Okay, it is enveloped, one, then double-stranded DNA, isn't it? Replicates in the nucleus. Okay, so then and 4. What is the typical CPE inclusions that are seen in the nucleus? Cowdrey type A, yes. Cowdrey type A, basophilic. Okay, so these are the important characteristics of HSV1. And where does it remain latent? Usually trigeminal ganglion. Okay, fine. So these many characteristics of the HSV1 you should know. Now let's look at the infections caused by HSV1. What's a primary infection? Where do you normally see HSV, herpes simplex viral infections? Where do you normally see it? Skin, yes, above the waist. Now it's not strictly, but in general above the waist, skin and mucosa, isn't it? Skin and mucosa. So skin, mucosa, and please describe the typical lesion of HSV. How will you, when you are looking at a patient, what do you think the patient will come with complaints, or what will you see in an HSV infected vesicular, yes, vesicles. So HSV vesicles, fluid filled, yes, this is so important, okay. So HSV1, HSV2, and which is the third virus which has vesicular lesions? VZV. So these three infections, this is typical. Vesicles which might later on become ulcer, okay. So this would be the typical description of a lesion of HSV infection. Now give me the examples of HSV infection. You have gingivostomatitis, then cold sores, isn't it? Cold sores, fever, blisters, common infections. Then, okay, finish off the skin manifestations. Gingivostomatitis, reactivation is cold sores. Anything else? Keratoconjunctivitis. Good. You see, you know how we teach the students to remember the infections? Start from the, yes, top. So, encephalitis. Next, eye, keratoconjunctivitis. Mouth, gingival stomatitis, fever, blisters. Okay. Skin, contact sports, skin to skin contact, gladiators. Do you remember? Herpes gladiatorum. What is that? That is lesions on the skin. Usually, suppose say somebody has herpes virus HSV1 infection and skin to skin contact. Formerly it used to be seen in gladiators. Now we don't have gladiators anymore, except we see movies, except they, you know. So people who, contact sports. So if you have, because remember, how is this infection transmitted, the virus? Mainly through the skin or mucosa, isn't it? So somebody has herpes lesions on the skin and skin to skin contact, the virus can be transmitted. So that's one. Anything else similar to that? Okay, it is herpes gladiatorum. And fourth is, have you heard of herpetic whitlow? What is that? Herpetic whitlow is usually lesions that are seen on fingers. Who are likely to get herpes lesions on fingers? Healthcare personnel, dentists, even sometimes even infants, because they tend to keep, thumb sucking, as well as infants sometimes tend to put their fingers, you see, in the mouth of, other adults. So what happens is, if they have herpes infection, the children can get lesions on the fingers. So these are the skin, and then of course you have the encephalitis or meningitis or encephalitis. Okay. So that's about the herpes infection, its reactivation, and the, yes. Herpetic whitlow. Herpetic whitlow are usually lesions seen on the fingers. Okay. So these are infections that are commonly associated with HSV1, and then of course you have meningitis, encephalitis, primary infection or reactivation. Okay. So this virus has a propensity to be latent, and then it can get reactivated. What are the stimuli for reactivation? Stress, yes. One of the main stimuli is stress, exposure to extremes of temperature, okay, yeah. Immunosuppression, yes. These are situations where you could probably get, that's why students often get cold sores, fever blisters. Close to the exams, they usually have a reactivation of herpes, which is very common, mainly because it is stress induced. So that's about the HSV1. Now, if you look at HSV2, all these remain the same, except that, what are the infections? Yes, HSV2, genital herpes, and then what is the most important complication of genital herpes in a woman? Neonatal herpes, yes. Neonatal herpes, this is a devastating infection because the neonate has very immature immune system, and remember, these infections are mostly asymptomatic. Many women are, in fact not only women, herpes infections, they become asymptomatic, and asymptomatic individuals are still shedding the virus. So women who are asymptomatic, they can transmit the infection to the newborn, and it's a devastating infection in the newborn. Okay, so genital herpes, and what's the other complication of another serious infection is encephalitis. Encephalitis with HSV1 and 2. Okay, so HSV1 and 2 both can cause encephalitis, and many cases it's a reactivation. So these viruses remain latent in the sacral ganglion, and Remember, recurrent infections and reactivations are common. So, okay, yes. So, where do you see the encephalitis? Where do you normally see the lesions? The temporal lobe lesions, that is typical of HSV encephalitis. So, since the temporal lobe is affected, the patient would manifest with, of course, you have symptoms of encephalitis. What else? Huh? No, during what are the, anything typical about the symptoms? Person will have encephalitis, seizures, hallucination. Seizures, hallucination are common in HSV infection, HSV encephalitis. These two are commonly seen, and they're very fond of giving the temporal lobe lesions as a clue to know that it is a case of herpes simplex virus encephalitis. Now, we are talking about the, it becoming latent in the sacral ganglion. During latency, what is the form of the virus? When herpes virus is latent, do you see the entire virus, or do you? What happens to the virus? Does it stay as an entire virus with the envelope and everything, or it's very important? Okay, let me put it this way. What is the treatment for herpes simplex viral infection? Acyclovir. What is the target of acyclovir? What's the target? DNA polymerase. DNA polymerase. When is DNA polymerase produced? When does the virus produce DNA polymerase? When it's replicating. Okay. So now the virus is latent. Can you treat them with acyclovir during latency? Why not? Why? Because it's not replicating. During latency, the virus is not replicating. There is no target. There is no DNA polymerase. Not only that, for acyclovir, what else is required? Thymidine kinase. The virus has to produce thymidine kinase. So during latency, herpes viruses are not, HSV is not replicating. What is the form? It is just a DNA. It's just a double-stranded DNA. Okay. So all that you can see in the sacral ganglion or trigeminal ganglion would be just a double-stranded DNA, and it is not integrated with the host nucleus. You know, there are some other viruses which will integrate its DNA. It just stays non-integrated, okay, as just the nucleic acid. What happens is, when there is a reactivation, some of the suppressor proteins, its repression is taken off, then the virus starts replicating, travels down the nerves, and then you see the reactivation. Okay. So these are the most essential points about herpes viruses, at least about the virus, the disease, and how it remains latent. Another important thing that you need to know is, how will you confirm a case of herpes virus infection? What are the lab diagnostic tests? Okay, Zank smear is what will you use for the Zank smear? What specimen will you collect for the Zank smear? So you have the Zank smear, yes. Let me just move to the next page. Sorry. Yeah, so the Zank smear, this is another commonly asked question, is from the vesicle fluid, isn't it? What are you demonstrating in Zank smear? You are demonstrating the CPE. You are taking the vesicle fluid, which will have the infected cell. And what is a typical CPE? the infected cells will stick to each other and form giant cell or syncytium. Giant cell, syncytium. These are the infected cells. The host infected cells inside those vesicles are all sticking to each other. So you will see multiple nuclei, giant cells in the Zhang smear. This is typical of HSV infection. What else? What other test? Yes, you can do an immunofluorescence staining. 2, you can do an immunofluorescence staining. Okay. Then, if you are suspecting encephalitis or meningitis, what is the gold standard? The PCR. Yes, please know that. So, PCR is for the gold standard for encephalitis or meningitis. Why is it so important to know whether HSV is causing the encephalitis or meningitis? Because for this viral infection, you have a treatment therapeutic option, isn't it? Acyclovir. For other viral infections, many viral infections, you can't treat. At least for this, you can treat. So that's why it's very important to confirm if it's an HSV infection, and you have the PCR technique. So at least you know that it's HSV. You can treat the patient. What will happen if you treat a patient who is, you're suspecting encephalitis with HSV, but it is not HSV, and you did not have any means to confirm it, and then you put the patient on acyclovir? What will happen? He doesn't have HSV infection, but you have given acyclovir. He has encephalitis with something else. Will the encephalitis have any? What happens to the acyclovir? Nothing happens. Why? Because? Why nothing happens with acyclovir if the infection is not caused by HSV and you're giving the patient acyclovir? Acyclovir, for it to exert its action, has to be activated or phosphorylated by thymidine kinase that is produced by the virus, isn't it? Thymidine kinase, first phosphorylation is through thymidine kinase produced by the virus. So if there is no HSV, there is no activation of the acyclovir. So that's it. The acyclovir is not activated at all. Okay? Okay. So that's about the HSV 1 and 2. These are mainly the points that they expect you to know about the HSV virus. Yes. Yes, host cell. That's where it remains latent, isn't it? No, it is just as a nucleic acid. It sheds its envelope, everything. It's just the DNA of the herpes simplex virus. That's why treatment during latency has no effect. Yep. 1 and 2. It's a characteristic of the herpes simplex virus. In fact, HSV2 is more known to cause, of course, both cause encephalitis, but HSV2 more as a reactivation of a genital infection. HSV1 can be a primary infection with the virus or reactivation. But most of the cases of encephalitis are reactivation of both the, HSV1 and 2, mostly. Okay, so the next virus, that is VZV. Let's look at VZV. Same characteristics, enveloped double-stranded virus. What are the classical manifestation of varicella zoster virus? Starts off with a rash, and then you see the vesicular rash, which usually starts on the scalp and face and then spreads downwards, and you see a crop of rash mostly concentrated on the torso. Okay, central, you see most of the rash concentrated on the torso. And how does the rash appear? All at one time or in successive crops? Okay, successful crops. Okay, so VZV infection is quite mild in children, doesn't cause any complications. But what happens if an adult gets infected or adult gets VZV for the first time? What's a complication of varicella zoster viral infection in adults? Why is it so important that it's better you get VZV during childhood? One of the major complications is viral pneumonia. VZV pneumonia is a killer. Adults as young as even 35 to 40 years, if you get VZV, they are more prone to severe viral pneumonia. That's one of the major complications, and also sometimes meningitis with VZV. Okay? In children, it's a mild infection, no problem. But adults are at great risk of severe VZV. That's one category of individuals in whom VZV can be severe. What's the second category? So, adult pneumonia, 2, elderly, immunocompromised, and third, newborn, born to infected mothers. Okay? Now, why is it so devastating in these individuals? Because in the elderly, they have weak immune system. Extremes of age, newborn and the elderly, because their immune system are weak, they are very prone to severe devastating varicella infection, and also the immunocompromised, especially somebody who is undergoing chemotherapy. So one of the commonly asked question is, say for example, a grandmother, was visited by, the grandchild who has, the next day the child is, diagnosed with VZV infection. What will you do to the grandmother immediately? What kind of protection should be offered to the grandmother? That's one of the commonly asked questions. Grandmother was exposed to VZV. You have to give the grandmother, yes, immunoglobulin. Newborn, also immunoglobulin. Say for example, the mother had varicella zoster during the last trimester of pregnancy, or just 2 weeks before she delivered. She has chicken pox. You have to protect the newborn, give immunoglobulin. Is there a vaccine for VZV? Why not give the vaccine? The vaccine is live attenuated, and it is contraindicated in all these individuals. These are people who need the vaccine, who need protection, but you can't give the vaccine because it's a live attenuated vaccine. So the only, you give them immunoglobulin, varicella immunoglobulin. Okay, so this usually, because in varicella infections, these are the questions that they normally ask. Okay, so you have someone who is elderly, newborn, born to a woman who had chicken pox infection, because a newborn has a potential of getting infected even during vaginal delivery, because remember, the varicella lesions are seen on the mucous membrane. Not only that, the virus can also sometimes, mainly because of the body fluids, which will transmit the infection. So immunoglobulin should be given to these individuals. Like say for example, you have a child who is undergoing chemotherapy. Child is exposed to the sibling who has varicella viral infection. They should be immediately given the immunoglobulin to protect. Okay. Now another question that they normally ask is, okay, so this virus remains latent, and what's the reactivation? Reactivation of VZV infection is shingles. And what's a classical presentation of shingles? You see vesicular lesions, dermatomes, isn't it? It is localized band. Why is it called herpes zoster? Herpes. What's herpetology? Hepatology? Anybody? Hepatology is the study of reptiles. So the lesions on the skin resembles like alligator skin, reptilian skin. That's why the name herpes. And zoster, zoster refers to a belt. In Greek, it refers to a belt. So you see a belt-like lesion, isn't it? Because the lesions are localized to a dermatome, you normally see a belt-like lesion, usually on the chest, abdomen, thighs. Always it's a belt, because the dermatome that's supplied by the nerve, you just see a crop of vesicular lesions on the skin. So that's shingles. Now the question is, say for example you have, somebody has shingles in the family, and the grandmother who's never had chicken pox is exposed to the person with shingles. What is she likely to get? Yes, she will get chicken pox and not shingles. You don't catch shingles from someone else. You can get chicken pox from another person who has shingles because it's the chicken pox virus. Okay, the virus doesn't change. The manifestation of reactivation is different. So primary infection, chicken pox. You see lesions all over. The virus goes latent and then reactivates as shingles. Okay, yeah. The grandmother. Okay, the grandmother, see chicken pox, you usually you are immune for life, okay? But as she's, say for example, if she's an 80-year-old grandmother, there's every possibility that her antibody titer has waned. So you don't take the risk, you give her immunoglobulin. Shingles, okay, the shingles vaccine is a more recent vaccine that is actually recommended for those individuals who are in the 50s and 60s. I don't know whether 80-year-old it's advisable to give the vaccine. I don't know. 50, 60 years old, yes. But immunoglobulin is anyway given to, especially these individuals who have been exposed to the virus. Yes, you don't take the risk because the antibody titers can wane. Okay, so that's why. Okay, so that's about the VZV, the same cytopathic effect as HSV. Okay, so next we move on to the next important virus, that's the EBV virus. EBV. Yes? Huh. Okay, so HSV1 is more commonly associated with meningitis. HSV2 mainly causes encephalitis. One can also cause encephalitis. Okay? One can cause meningitis and encephalitis. Two is mainly encephalitis. Okay? The difference is that in encephalitis, the parenchyma is involved, and that's why the post-infectious sequelae is more severe in the encephalitis than meningitis. So, talking about EBV, the Epstein-Barr virus, what's the target cell? Okay, the target is a B cell. And it binds to CD21 bar CR2, okay, which is the receptor for complement. Yes, so that's a pretty high yield question that they normally ask. Okay, and it can remain latent in the B lymphocytes. What's a common infection caused by EBV? Mononucleosis, yes. So infectious mononucleosis, mostly seen in young adults. It rarely causes any major infection in children. Okay. So what are the characteristic manifestation of infectious mononucleosis? Pharyngitis, then yes, lymphadenopathy. Then, what else? Yeah? Yes, splenomegaly, hepatosplenomegaly. Even the liver is affected. You see elevated enzymes. Sometimes you'll see a rash. And anything else? Yes, fever. Yes. And something else that is very classical about mononucleosis is fatigue. fatigue that can last for sometimes months. Okay, so what is the reason that this is not so, doesn't cause much symptoms in children, but it causes mononucleosis, all these symptoms in adolescent? Okay, so it's very interesting. EBV is one of the viruses. The manifestation, you know, what are the other infections caused by EBV? Okay, we'll just take a break and come back to that. Yes? Burkitt's, yes. Then? Nasopharyngeal carcinoma. Then? Hairy leukoplakia. Okay, so this is seen in usually AIDS immunocompromised patients, isn't it? Burkitt's lymphoma also are seen in individuals who have weak immune system. We mostly seen in the poorer developing countries. Of course, there are other cofactors too. Whereas EBV, mononucleosis, is usually seen in healthy immunocompetent individuals. So the manifestation of EBV is very closely related to the immune status. Children, because they have slightly weak immune system, do not vigorously respond to EBV. The manifestation of infectious mononucleosis, the symptoms are all because of a vigorous immune response. A young adult responds vigorously, his immune system responds so vigorously to the virus. The manifestation, the rash, the pharyngitis, all the symptoms are mainly because of the vigorous immune response. Okay, so as you can see in hairy leukoplakia in AIDS patients who have very weak immune system, the manifestation is different. So the same virus manifests differently again depending on the immune systems. Children, you hardly ever report, nobody, infectious mononucleosis is not a disease of the children. Then the other important what they normally test about EBV is, what are the diagnostic tests? Okay, so what is the monospot test? What are you testing in monospot? Yes, you're looking for non-specific antibodies or heterophil antibodies. What are heterophil antibodies? Antibodies produced against? They are non-specific. They are not specific for the virus. Okay, they are non-specific antibodies, yet you see them in this EBV virus. Cross-reacting antibodies. During the viral infection, it induces antibodies that can cross-react with other. Anything else that you would see in which is useful as a diagnostic tool? Downy cells. What are they? Yes, please remember, Downy cells are not B cells, they are T cells. T cells. Why do you see T cells? Enlarged T cells. Yes, because it's a viral infection, isn't it? Which cells will be stimulated? The T lymphocytes. So in EBV, the T lymphocytes are stimulated and you see enlarged T lymphocytes in the peripheral blood, which is again, they're called the Downy cells. Okay. Then lots of spurious antibodies, non-specific antibodies are produced in large amounts, and that is again partly responsible for the immune, immune reaction, the rash and all that you see in case of EBV. Now this rash, does it become worse with something? Yes, this rash of EBV becomes worse with the antibiotic ampicillin. If you give this patient ampicillin, some of the patients, they come back with severe worsening rash. Ampicillin induced rash in case of worsening rash. Again, this because of a kind of an allergic reaction. Okay, so that's about EBV virus and it's the various infections that's caused by EBV. Okay, then next CMV. Okay, so what are the target cells of CMV? Monocytes. Yes, lymphocytes. And they can infect many cells and they remain latent. Okay, mainly in these cells. Then, what infections do you associate with CMV? What does it cause in an immunocompetent adult? CMV, have you thought of, does it cause any disease in immunocompetent? Huh? Mononucleosis like syndrome. Okay, so it causes a mononucleosis like syndrome, which is nothing serious. Nobody, you know, mononucleosis like. So, what you should remember is CMV is not at all a problem in an immunocompetent adult. Almost 95% of the population have been infected with CMV, and we all have this virus latent. But it doesn't cause any problem until and unless, yes, when you are immunocompromised or immunosuppressed. Immunosuppressed as in transplant. Yes, it's a big problem in transplant patients. Remember, even the donor's organ might have CMV. Everybody has this virus latent. Or in AIDS patients, these are the two category of individuals in whom reactivation of CMV can cause major problems. Okay, in AIDS patients, what are the manifestation of CMV? Retinitis. Then AIDS patients, retinitis, chorioretinitis, then esophagitis, pneumonia, and colitis. Know this. This is important. Okay, so colitis, pneumonia, esophagitis, and chorioretinitis are the manifestation of immunocompromised individuals. AIDS, transplant patients mostly present with pneumonia, CMV, pneumonia. Okay, so these two category of individuals with CMV, who else is at risk of CMV? Yes, it can cross the placenta. This is a virus which crosses the placenta, and it causes inclusion disease in the newborn. How does it manifest? Inclusion disease in the newborn? Multiple symptoms, you know, microcephaly, periventricular calcification, jaundice, rash. Okay, so inclusion disease, newborn with CMV infection can manifest with multiple symptoms, and CMV, congenital transmission of CMV, congenital infection, the most common cause of congenital infection in the US is CMV, because almost everybody is infected with this virus. Okay, and especially if the mother, yes. Not really, because even toxoplasmosis, there are others which will manifest similarly. So what they normally do is they'll give you some clue. Other clue that's specific for the virus, like intranuclear inclusions. So you should be, they won't say owl's eye inclusion, that is so obvious. So they will say that the newborn cells, say the, you know, cells in the urine cells had, you know, intranuclear inclusions or enlarged nucleus. So you should immediately figure out, oh, this is CMV. Okay, so in a newborn, typically you would see characteristic CPE, that's the owl's eye inclusions in the nucleus. Okay, that's what you need to focus on. So this is a virus which can cross the placenta. It is the most common cause of congenital infection in the US, because it crosses the placenta, causes cytomegalic inclusion disease, which manifests with multiple symptoms, but they give you a clue about the characteristic of the virus. Or what's the other way that you can confirm newborn infection? IgM in the newborn. Okay, so CPE or, yeah. You have a question? You have a question? Okay. So, the other important aspect about CMV is, what's a drug of choice that is used to treat CMV infection? Ganciclovir. You can use ganciclovir, or you can use foscarnet, but mainly ganciclovir. Again, what is it? What type of a drug is ganciclovir? Okay, its target is DNA polymerase, but what category? Acyclovir and ganciclovir are? They are nucleoside analogues. You must know it like that. These drugs are nucleoside analogues. They resemble nucleoside. So when the DNA polymerase is adding on the nucleosides, it mistakes the drug to be a nucleoside and it tries to incorporate it. That will cause chain termination. Okay? These are all nucleoside analogues. Ganciclovir, acyclovir. Okay. So that's about the CMV. Then HHV, HHV6, what does it cause? Roseola, Roseola infantum subitum. What's the characteristic manifestation? Yes, baby has high fever, infant high fever, then the fever stops. This is important. Fever subsides. And then you see the rash. Okay? So you don't see the rash with the fever. That's typical of HHV6. High fever, fever goes down, then the rash. It's mainly immune mediated. Okay? So characteristic of HHV, same, double-stranded DNA virus. Nothing unusual about it. Okay? Then, Kaposi sarcoma, HHV8. So HHV8 Kaposi sarcoma virus, mainly, where do you see the lesions? Skin and mucous membrane. Now remember, all these herpes virus, VZV, all of them, you see them in the skin and mucous membrane. You see the purplish blotchy lesions, and it is almost exclusively seen in immunocompromised, mainly AIDS patients. Okay, so okay, so it's about time. So did we covered all the herpes viruses, isn't it? Yeah. So what we'll do is on Tuesday, we'll quickly try to finish off all the remaining, at least the most important viruses. I would suggest that at least if you can just go over the, isn't it time? Yeah, it is. 2 minutes, yes. So, okay, so quickly in 2 minutes I can finish one more important virus. Let me, okay. What about molluscum contagiosum? This is an important virus, sorry. Molluscum is caused by? Which virus? The pox virus, yes. What are the typical lesions? Yes, pearly white, umbilicated, because it has a central depression. These are not vesicles, okay? Please do not confuse them with vesicles. They are not vesiculated lesions. Pearly white, umbilicated with a small stalk. You see these lesions. How do you get this infection? How does a virus? Through skin. The infection is acquired through the virus entering the skin, and where the virus enters, it multiplies locally, and you see the lesions. The virus does not enter the bloodstream. Okay, so if you were to take a biopsy of or a histopathology of this umbilicated lesion, where will you see the virus? This is the skin, sorry, cell. This is the nucleus. Okay, so what is the pox virus? Is it RNA or DNA? DNA virus. So where should it replicate normally? Yeah, it does not replicate in this nucleus. Yes, you will find the virus here in the cytoplasm, which is unusual, and this is what they would like to ask. Okay, so this is a pox virus replicates in the cytoplasm. Therefore, what other characteristic will they give you as a clue? What does it bring along? Yes, polymerase. It has to carry its own DNA polymerase. Okay, so this is something which you need to remember. They will give you characteristics of molluscum contagiosum, and then they will ask you whether it's replicating in the cytoplasm or nucleus. Students often confuse this with HPV. They confuse this with HPV, they confuse it with HSV lesions. That is vesicular HSV, HSV, VZV vesicular, and HPV is warts. Okay, these are pearly umbilicated lesions multiplying in the cytoplasm. Okay. Okay, so I'll see you on Tuesday, and we'll try to finish all the viruses.